Usually when you picture the brain, it's sort of like this master control room, right? Like a supercomputer with perfect wiring where every single signal goes exactly where it's supposed to go instantly.
Right, yeah. Highly efficient, flawless execution. I mean, at least that's the ideal we think of.
But then when you actually dive into the pharmacology of the brain, especially how we treat diseases that, break that machinery down, you realize it's really less like a supercomputer. It's more like a walled medieval city.
Oh, absolutely. A fortress.
Yeah, it has these heavily guarded gates. And sometimes, to fix what's broken inside, you can't just knock on the front door and walk in. You have to get incredibly creative. I mean, you essentially have to become a smuggler.
A biological smuggling operation, yeah.
Hmm.
Because the brain's security system is fundamentally designed to keep things out,
Mm-hmm.
which, makes repairing it from the outside one of the hardest challenges in modern medicine.
Exactly. So today we are taking this massive stack of pharmacological notes, historical research, medical breakthroughs, and we're using all of it to demystify anti-Parkinson drugs. We're going to explore the incredible, messy, and frankly wild science of how we actually manage to restore dopamine to a failing brain.
Which is such an important topic for people to understand.
It really is. Parkinson's disease affects roughly 1% of people over the age of 60, making it one of the fastest growing neurological disorders on the planet. But even beyond the disease itself, understanding these drugs gives you this profound look at how your own brain balances movement, reward, and just behavior in general.
Yeah, and to really grasp how sophisticated modern treatments are,
Yeah.
we kind of have to start by looking at how entirely blind medicine was before we understood the brain's biochemistry.
Right, we were just guessing.
Totally guessing. It's a story that begins way back in 1817 with an English surgeon named James Parkinson. He published this monograph called An Essay on the Shaking Palsy, describing a disease he called paralysis agitans. But the crazy thing is, he didn't discover this by running clinical trials. He barely even examined the patients formally. He mostly just watched them walking around the streets of London.
Okay, wait, let's unpack this. He writes the defining medical text on this whole condition just by, observing strangers' posture and tremors from afar.
Pretty much, yeah. I mean, he was a keen observer of the way people moved. He noticed the stooped posture, the resting tremor, the shuffling gait. But observing the outside obviously doesn't tell you anything about what's broken on the inside.
Right, it's just the surface.
Exactly. So jump forward to Paris in the 1860s. The French neurologist Jean-Martin Charcot is working at the Salpêtrière Hospital. He's the guy who actually renames the disease after Parkinson.
Oh, nice of him.
Yeah. And Charcot was also among the first to systematically try a pharmacological treatment, but he finds it entirely by accident.
How so? What happened?
Well, he noticed that one of his patients, who was dealing with severe drooling, had that specific symptom improve when given belladonna alkaloids, specifically this compound called hyoscyamine. Crucially, though, Charcot noticed the patient's tremors also seemed to calm down. These are what we now call anticholinergic drugs.
Wait, so for an entire century, the gold standard of care was basically treating a side effect, drooling by pure accident, with just zero understanding of the underlying machinery.
That is exactly right. Medical breakthroughs very often precede biological understanding. Charcot and the doctors who followed him, they had no idea why the belladonna worked. Today, we know these early drugs didn't touch dopamine at all.
They didn't.
Not at all. Instead, they rebalanced the brain by targeting a totally different chemical, which is acetylcholine. In a healthy brain, specifically in a region called the striatum, movement is managed by this really delicate scale.
Like a seesaw.
Right. On one side, you have dopamine, on the other side, acetylcholine. When dopamine drops, acetylcholine becomes relatively too high. That imbalance causes the tremors and the stiffness. So the belladonna alkaloids lowered the acetylcholine side of the scale.
Huh. So it's like fixing a wobbly table by sawing off a different leg instead of, extending the short one. It sort of stabilizes things, but you're not actually fixing the missing piece.
That is a great way to put it. And that crude workaround was the best we had until the mid-20th century, when the actual biochemical root of the disease was finally uncovered.
Okay, so when did that happen?
In 1957, a Swedish scientist named Arvid Carlsson ran an experiment that fundamentally changed neuroscience, and it eventually won him the Nobel Prize in 2000. He took rabbits and gave them a drug called reserpine, which basically empties the brain's storage of specific chemicals.
And what happened to the rabbits?
They became completely akinetic. They were just frozen, unable to move at all. But then he administered L-DOPA, which is a metabolic building block for dopamine.
And the rabbits just wake up.
They woke up and started moving normally again. And this was a radical claim at the time, because back in the 1950s, scientists actually dismissed dopamine.
Wait, really? Why?
They thought it was just a useless intermediate step, like a piece of biological scrap left over while the body was busy making norepinephrine. But Carlson proved that dopamine wasn't just a stepping stone. It was a vital neurotransmitter in its own right, and depleting it caused that frozen Parkinsonian state.
Okay, so that gives us the mechanism in an animal, but how did they connect that to the people actually suffering from the disease?
That happened a few years later, in 1960. The Austrian pharmacologist Ola Hornikiewicz and Herbert Ehringer examined post-mortem brain tissue from human Parkinson's patients. They looked at the striatum and found that the dopamine levels were completely decimated.
Like, how decimated are we talking?
Reduced by a staggering 80 to 90% compared to healthy brains.
Oh, wow. So we finally found the core problem. Parkinson's is essentially a dying dopamine factory. The specific neurons that produce dopamine, which are located in a tiny region called the substantia nigra pars compacta, right?
That's the one.
Yeah, they are progressively dying off. Which brings us to the central pharmacological challenge of this entire deep dive. We know exactly what is missing. The brain needs dopamine, but you can't just swallow a dopamine pill and you can't inject it into your arm.
Right. And the reason for that brings us right back to your walled medieval city analogy. The brain is protected by the blood-brain barrier. It's this tightly sealed lining of cells around the blood vessels that keeps toxins and pathogens out of your sensitive brain tissue.
It's the wall.
Exactly. And dopamine, chemically speaking, is too polar and too large to cross that barrier. If you take it directly, it just circulates in your blood and never reaches the neurons that actually need it.
It's like trying to deliver a fully built sofa into a walled city with tiny gates. You know the people inside desperately need the sofa, but you just can't fit the completed sofa, which is the dopamine molecule, through the gate.
Right.
So instead, you smuggle in the raw wood and fabric, which is the precursor, Levodopa, and you let the carpenters already inside the walls build the sofa themselves.
That is exactly what happens. Levodopa is the perfect smuggled good. Unlike dopamine, levodopa is structured just right to hijack an existing gate. It crosses the blood-brain barrier using an active amino acid transporter.
Well, that's clever.
Yeah. And once it gets safely inside the brain tissue, it finds your carpenters, an enzyme naturally present in the brain called dopa decarboxylase. This enzyme strips a carboxyl group off the levodopa, converting it into actual dopamine right there on site. You smuggle in the raw material and let the brain's natural machinery finish the job.
It's an incredibly elegant first principles trick, but, I mean, biology rarely lets you get away with something that simple. There's a massive immediate flaw with this smuggling operation, isn't there?
There's a huge flaw.
Because those carpenters, that D-dopeg decarboxylase enzyme, they don't just live inside the walls of the brain. They are everywhere in the body. They're in your gut lining, your liver, your peripheral blood vessels.
Yeah, which creates a devastating peripheral problem. If you give a patient a pill of pure levodopa, those enzymes in the gut and the bloodstream just attack it immediately. Roughly 95 to 99% of the levodopa gets converted into dopamine before it ever reaches the blood-brain barrier.
Which means the brain is still starving for dopamine, but now the rest of the body is suddenly flooded with it.
And the body cannot handle that flood at all. Dopamine in the peripheral bloodstream triggers severe, debilitating nausea, intense vomiting, and dangerous fluctuations in blood pressure.
Oh man, that sounds awful.
It was. Early trials with pure levodopa were incredibly difficult for patients to tolerate.
So in the 1970s, scientists invent a secondary drug specifically to protect the first drug. They basically realize they need a bodyguard, and they create a molecule called carbidopa. Carbidopa's entire job is to shut down that converting enzyme. But here's the genius part. Carbidopa itself cannot cross the blood-brain barrier.
Right, it acts as the ultimate escort. You formulate levodopa and carbidopa together in one pill. As they travel through the bloodstream, the carbidopa acts like a shield, blocking all those enzymes in the gut and the blood from metabolizing the levodopa.
It's taking the hits.
Exactly. It escorts the levodopa safely to the gates of the brain. But because the carbidopa can't get inside, it stops at the wall. The levodopa crosses over alone, safely entering the brain where the internal enzymes are still active, just waiting to convert it into dopamine.
It is brilliant. This combination multiplied the effective dose reaching the brain and virtually eliminated those horrific peripheral side effects. Right?
It changed everything. It paved the way for doctors like George Cassius in the late 1960s to start safely titrating oral levodopa up to high doses, leading to results that looked like absolute magic. Patients who had been rigid and nearly immobile for years were suddenly standing up and walking.
That must have been wild to see.
It was a revolutionary era in neurology.
Hmm.
You often see this period referenced alongside Oliver Sacks's famous book, Awakenings, where he used these exact levodopa breakthroughs in 1969. Now, his patients were a unique population. They had post-encephalitic Parkinsonism from a 1920s sleeping sickness epidemic, but the pharmacological principle was exactly the same.
Wow.
And to this day, more than 50 years later, the levodopa-carbidopa combination remains the single most effective symptomatic treatment for Parkinson's disease ever developed.
Okay, wait, let's pause on that word symptomatic. Because if this combo is basically a miracle cure that perfectly replaces the missing dopamine, why doesn't it just solve the disease permanently? Why are we still desperately researching new treatments?
Because replacing the dopamine does not stop the factory from burning down. Anti-Parkinson drugs treat the downstream deficit. They do not touch the upstream pathology.
Oh, okay. Meaning what exactly?
The actual underlying cause of Parkinson's involves the misfolding of a protein called alpha-synuclein, which clumps together into toxic aggregates known as Lewy bodies. This protein pathology is what is actually choking and killing the dopamine neurons.
Ah,
Levodopa does absolutely nothing to stop those neurons from dying. It only supplies dopamine to mask the loss. As of right now, no anti-Parkinson drug has been definitively proven to be disease-modifying in humans. They don't slow, stop, or reverse the underlying neurodegeneration.
which means the foundation is still crumbling underneath the treatment. And that fundamentally changes how the drug works over time. Usually when a patient first starts taking the levodopa-carbidopa therapy, they enter what clinicians call the levodopa honeymoon, right?
Yes, the honeymoon phase.
For like 3 to 5 years, symptom control is smooth, they take a pill and they feel normal all day, but then the honeymoon inevitably ends.
It ends because of that crumbling foundation. In the early stages of the disease, even though a lot of neurons have died, the brain still retains a biological buffer. The remaining healthy dopamine neurons act like sponges.
Okay.
They absorb the levodopa, convert it, store the dopamine in little vesicles, and slowly release it as the brain needs it. They act as shock absorbers, smoothing out the peaks and valleys of the drug levels in the blood. But as the disease progresses and those remaining healthy neurons die, that storage capacity vanishes.
So they lose the shock absorbers, the brain becomes entirely dependent on the exact amount of drug in the blood at any given second.
Exactly.
Yeah.
This leads to a phenomenon called wearing off. The symptoms start creeping back in before the next dose is even due. Patients develop violent on-off fluctuations. 1 hour, they are moving freely, and the next, they are entirely frozen.
That sounds exhausting.
It is, and it creates an even more brutal complication, levodopa-induced dyskinesias.
Let's clarify the difference here for everyone because it's crucial. Bradykinesia, which means slowness of movement, is the core symptom of the disease itself. But dyskinesia, which are these involuntary writhing, jerking movements, is a side effect of the drug. It happens when the medication overstimulates a brain that has lost its buffering capacity. The doctors end up walking this agonizing tightrope between undercorrecting, leaving the patient stiff, and overcorrecting, causing them to writhe uncontrollably.
It's a very difficult balance.
Yeah.
So to get around this reliance on the dying factory, scientists developed an entirely different class of drugs to try and trick the brain.
Trick it how?
Well, instead of supplying raw materials, they created dopamine agonists, drugs like pramipexole or ropinirole. These molecules don't need to be converted by any enzymes. They bypass the dying neurons entirely, bind directly to the dopamine receptors, and activate them. They essentially fake the signal.
You know, here's where it gets really interesting. A lot of people hear about these fading drug effects over time and assume the patient is just building a tolerance to the drug. Like with caffeine, you need a stronger cup of coffee to get the same buzz. Is that what's happening?
No, and that is a major misconception.
Yeah.
It is not pharmacological tolerance at all. The drug itself is just as potent as it was on day one. Yes. What is happening is that the biological target is changing, the disease is progressing, and the storage buffer is shrinking. But for a long time, this misunderstanding fueled a massive debate over neurotoxicity.
Right. There was a widespread fear that levodopa was actually toxic to the brain.
Exactly. For decades, some researchers hypothesized that the metabolic breakdown of levodopa created oxidative free radicals that were accelerating the death of the remaining neurons. Doctors were so terrified of this that they would intentionally delay starting patients on levodopa for years.
Wow.
They'd opt for those dopamine agonists instead, trying to save the levodopa for when things got really bad. But in 2004, the L-DOPA trial, published in the New England Journal of Medicine, finally put this to rest.
Oh, thank goodness.
Yeah, it rigorously tested early levodopa use and found zero clinical or imaging evidence that it accelerated disease progression. It ended the practice of reflexively delaying treatment, establishing the modern guideline, which is basically treat the symptoms when they impair a patient's life.
But relying on those dopamine agonists, the drugs that fake the signal, comes with its own set of incredibly strange, sometimes terrifying side effects. Because when you flood the brain with a chemical that mimics dopamine, you aren't just targeting the motor circuits that control movement, you are also blindly stimulating the brain's reward circuits.
And that is a huge problem. Dopamine is the universal currency of reward, motivation, and pleasure in the human brain. The pathways that control movement, the basal ganglia, are distinct from the pathways that control reward, the mesolimbic pathway.
Right.
But an oral pill doesn't know the difference. It goes everywhere. In a meaningful minority of patients, these dopamine agonists hijack that reward system, triggering severe impulse control disorders.
We are talking about sudden pathological behavioral changes, compulsive gambling, hypersexuality, binge eating, compulsive shopping. You have patients who have never had a gambling problem in their entire life suddenly draining their life savings at a casino purely because of a pill they took to stop their hand from shaking.
It is a profound illustration of how mechanical our decision-making and behaviors can be. The FDA actually had to add black box-style warnings for these medications because flooding those reward receptors can completely rewire a patient's impulses.
It really shows how chaotic pharmacology can be when you're dealing with a system as complex as the brain. And that chaos is a running theme in how we discover these treatments. Like, we talked about Charcot finding a treatment by trying to stop drooling in the 1800s, but we also have flu nurses in the 1960s. How did a drug called amantadine enter the picture?
Amantadine is a great example. It was developed and marketed in the late 1960s strictly as an antiviral medication to prevent Asian influenza.
Just a standard antiviral.
Yeah. But in 1969, a nurse happened to be treating a Parkinson's patient who caught the flu. She gave them amantadine, and she noticed an unexpected dramatic improvement in the patient's Parkinsonian symptoms. It was a pure bedside observation that led to the drug being thoroughly investigated and repurposed.
But wait, how does an antiviral medication do anything for a neurological movement disorder?
It took years to figure that out. We now know amantadine works by modulating glutamate. Glutamate is the brain's primary excitatory neurotransmitter. It acts like the accelerator pedal for neural signals.
Okay.
In a Parkinson's brain fluctuating on levodopa, that accelerator gets pushed down way too hard, contributing to those writhing dyskinesias we discussed. Amantadine subtly blocks certain glutamate receptors, turning down the volume on that excitatory loop. Today, it remains one of the few drugs highly effective at fighting severe dyskinesia.
So we cure a side effect of a Parkinson's drug using an antiviral medication discovered by a flu nurse. That's just wild. But the history of this field also has incredibly dark, tragic accidents. In the early 1980s, an event happened that completely changed our understanding of how this disease might start.
Yeah, you're talking about the MPTP outbreak of 1982.
Right.
In Northern California, several young, otherwise healthy drug users injected a batch of synthetic heroin. Within days, they arrived at emergency rooms displaying profound, permanent Parkinsonism. They were essentially frozen overnight.
That is terrifying.
It baffled doctors because Parkinson's is a slow, progressive disease of aging, not something that happens instantaneously to 20-year-olds.
Right. And a neurologist named J. William Langston took on the case, right?
Yes. Langston tracked the cause down to a specific contaminant in the botched synthetic heroin batch called MPTP. When MPTP enters the brain, an enzyme called MAOB metabolizes it, converting it into a highly toxic molecule called MPP plus Whey.
Okay.
This toxin specifically targets and destroys the dopamine neurons in the substantia nigra. It selectively annihilates the exact same microscopic factory that natural Parkinson's disease destroys slowly over decades.
So they gave themselves instant, irreversible Parkinson's.
They did. It was a human tragedy. But what's fascinating here is that it revolutionized Parkinson's research. First, it finally provided scientists with an incredibly accurate animal model. By using MPTP, researchers could replicate the disease in the lab to test new drugs.
Right, which they couldn't do before.
Exactly. Second, it launched the modern era of MAOB inhibitor research. Researchers realized that because the MAOB enzyme is what converts the chemical into its toxic form, blocking that enzyme prevents the poisoning. Today, MAOB inhibitors like selegiline are a standard part of Parkinson's treatment, used to prevent the breakdown of dopamine and prolong its action in the brain.
Okay, so if the core issue is that the cellular factory is destroyed, whether by a synthetic drug or by natural aging, the obvious mechanical question is, why don't we just build a new factory? Like, why can't we just transplant new dopamine-producing cells into the brain?
That was exactly the logic behind the fetal cell transplantation trials in the 1990s. It
Mm.
seemed like the perfect cure. Surgeons took fetal dopamine neuron tissue and grafted it directly into the striatum of Parkinson's patients. But biology, again, is not a simple machine.
Right.
Two highly rigorous NIH-funded trials showed that the transplants not only failed to provide consistent benefit, but they caused a catastrophic side effect.
Oh, man. What happened?
Some patients developed severe, untreatable runaway dyskinesias. You can place healthy dopamine cells into the brain, but you can't perfectly replicate the microscopic wiring and feedback loops that control them. The grafted cells survived, but without the proper regulatory signals, they just started dumping dopamine blindly and uncontrollably.
And since it's an implant,
Right, because it was living tissue permanently grafted into the brain, doctors couldn't just lower the dose like they could with a pill. The very sobering lesson frequently cited in neurology. Translating a brilliant theory from neuroscience into a practical living therapy is incredibly dangerous.
so we have streetwatchers in the 1800s, flu nurses in the 60s, and a bad batch of synthetic heroin in the 80s. It feels like we are constantly backing into these massive scientific breakthroughs by pure accident.
It really does, and it's exactly why the definition of an anti-Parkinson drug is so contested and broad today.
Hmm.
It constantly evolves based on these human experiments and observations.
So what does this all mean for you listening today? Parkinson's is, at its core, a story of a dying dopamine factory. Because the brain's walled city won't let dopamine through the gates, we learn to smuggle in the raw materials using levodopa. We learn to send that smuggler with a bodyguard, carbidopa, to protect it in the peripheral bloodstream.
Yep.
We learn to bypass the factory and fake the signal entirely using agonists, which unintentionally revealed just how closely our physical movement is tied to our deepest reward and impulse circuits. And we learned that doctors are constantly walking a pharmacological tightrope, managing shock absorbers that are slowly disappearing.
And this leaves us with a lingering provocative question drawn directly from that tragic synthetic heroin story. We saw how a single environmental chemical, MPTP, could perfectly mimic Parkinson's disease by specifically assassinating dopamine neurons.
Yeah.
As we watch the global rates of natural Parkinson's disease rise, it forces us to ask, could this slow, creeping epidemic actually be triggered by chronic, low-level exposure to similar, unseen environmental toxins?
Toxins that are just, existing in our daily lives.
Exactly. Things like agricultural pesticides, industrial solvents, or heavy metals. Scientists are actively investigating these links right now. It suggests that neurodegeneration might not just be a consequence of bad genetics or bad luck, but a reaction to the chemical world we've built around ourselves.
Wow. It really makes you realize that the walled medieval city of the brain isn't an isolated fortress. It is constantly breathing, absorbing, and interacting with the soil, the water, and the air outside its gates. Thank you for joining us on this deep dive. Keep questioning the world around you, and we'll catch you on the next one.